Okay, so good afternoon. I'm Dr. Clement Rose. I'm an internist here at Weiss Hospital. I do several things, including a private practice, as well as part of the teaching faculty here at Weiss Hospital. I've been here for longer than I want to say, but about 50 years since moving here into the uptown area. I think all of you probably know a little history about Weiss, but just to let you know, we're a very small but mighty community hospital here in uptown Chicago. And we are a teaching facility affiliated with at least 3 different medical centers. So we provide one of the best cares for our local residents in the community, and we're here to stay. So today, I've been asked to talk here at the Senior Center about prostate issues. So a couple of disclaimers. One of the organizations that I also volunteer for is the American Cancer Society. So I have borrowed some of their slides from a presentation I did a few years ago, updated to current year. So we thank the American Cancer Society for all the things that they provide for our cancer patients. As many of you know, we do have an active oncology/cancer center here at Weiss Hospital. So today we're specifically going to talk about prostate cancer, which I'm sure everyone knows, it only affects half the population, the half that happens to be male. However, even though the disease itself may only afflict the males, it afflicts everyone because there is always a good female behind every man. No doubt about that, right? So, you know, we have wives and other spouses, and we have daughters, and we have mothers who are related to the men. And obviously, when a man has an illness, it takes a family support effort to support that. And the same thing goes through, obviously, for all illnesses. But since today we're talking about men, I do want to acknowledge all the women online and in the room who have come to attend this presentation. And hopefully you'll get information that you can actually take back to your friends and family. So let's go ahead and get started. So cancer prevention and early detection in men. Unfortunately, prostate cancer is not one of those that we can really prevent. However, cancer in general can be detected early, for which there could be early treatments. And there are some cancers that can be prevented just by some simple lifestyle modifications. Exercise, eating right, more vegetables and animal products, keeping your weight down. These are lifestyle modification risk factors that, you want to go full screen? Mm-hmm. That can improve our ability to, let me see if I can do that for you, to reduce our risk of many cancers overall. Prostate cancer specifically has not been shown to be necessarily increased risk by obesity, but there are some other cancers such as colon cancer, pancreatic cancer, and other things that we deal with. Certainly though, obesity in itself is a high risk factor for bad health. It prevents you from doing a lot of the things that you would be able to do to keep active. And we know that inactivity leads to poor health, and which ultimately, in my opinion, leads to a poor immune system, of which cancer is one of those illnesses that might overtake you if your immune system cannot fight. All of us have heard of the word cancer, but many of us don't exactly know what it means. Cancer is simply when cells in the body grow out of control. Cells are growing every day, and sort of like the virus today, that as it afflict and affect more and more people, it changes. Well, the cancer cells are cells that were at one time normal, but because they're multiplying so often, errors are made, and then the cells start to grow out of control. So in general, that's what cancer is. And therefore, all of us have a potential of having cancer, but a great part of why we don't have it is that when cells get bad, so to speak, our body's immune system kind of handcuffs and puts these cells in jails and prevent it. But it's when our system is overwhelmed that now we have this cancer that grows out of control. So in general, about 1.9 million or almost 2 million people in the United States will be diagnosed with cancer this year. So that's quite a bit. Specifically prostate cancer, as we said before, it's only found in men. The prostate gland is a walnut-sized organ that's located in front of the rectum, behind the penis and under the bladder. So many men will tell you, that's why when they go to the doctor and they're getting a prostate check, there's usually the digital rectal exam in order to feel part of the prostate. But in reality, the only part of the prostate that you can really feel that way is the back end of it, which is probably only about a third or so, or it's less than half of the prostate. So even if your prostate's growing larger in the front, you may not appreciate it as a physician on the digital rectal exam. So other parts of examination and taking a good history and listening to your patient probably helps you in determining whether that patient is having a prostate issue. Must say though, most prostate issues are not cancer. Most prostate issues are just the prostate that enlarges. And as long as you are a man and you're getting older and still alive, your prostate will get larger. So we're all at risk for large prostates, the majority of which is not cancer. So prostate cancer specifically, the national estimates currently for this year are almost 250,000 new cases. So that is men who are never diagnosed before have a 250,000 incidence of a new cancer diagnosis. However, the death rate is estimated, this is directly from prostate cancer, to be about 34,000. Now, any death is not a good thing, but frankly speaking, though, we're all going to die one day. If you've ever been alive, anything that's been alive is going to die one day, whether it be a plant, an animal. However, our goal is to prevent premature and unnecessary death during productive years of life. If you were to compare the number of cases of prostate cancer to some of the other cancers, you'll find that prostate cancer afflicts many, many, many more people. However, the death rate, the mortality rate is relatively low compared to other things such as breast cancer, such as lung cancer, a totally preventable. At least 80% of the lung cancer can be prevented by not smoking. So we see that the actual deaths from prostate cancer is not as high as the mortality in other cancers. So in other words, more men die with prostate cancer from other causes than they actually die from the complications or the result directly of the prostate cancer. So hopefully that gives some of us some reassurance that having a diagnosis of prostate cancer does not mean automatic death sentence. The risk of prostate cancer is about 1 in every 8 men at some point in their lifetime. So hence the 250,000 per year, you make your calculations, it comes out to be about 1 in 8, as opposed to 1 in 5 for breast cancer for women. Oops, I think we went a little too far there. Okay, let's go back. There we go. So there's a slide here about the prostate cancer cases in the past couple of years here at Weiss Hospital. And I don't know if it projects pretty good. If you look at it, the blue ones are in the age 50s, the orange is age 60s, 70s. You can see that the majority of the prostate cancer cases seem to occur in the age 60 age group on up. And that's what we see in the real world. It's usually a cancer of middle-aged to upper-age men. However, we do have some groups, some younger men who are more at risk for getting prostate cancer at an earlier age. The earliest prostate cancer patient I've seen has been someone in their early 40s. Prostate cancer cases at Weiss based on ethnicity. We see that the Black ethnicity has been the most here at Weiss. Remembering that we're in Uptown, a community of much diversity. If you look at the white population, they're a fair amount, but again, they tend to be the majority of the population in Uptown still. But as you can see, it afflicts everyone across the entire spectrum. However, our Black or African American community seems to be afflicted more at a younger age, and many times with a more advanced disease by the time they come to seek help. Treatment at Weiss that we offer. So in prostate cancer, there are several options for treatment. One treatment is not to do anything aggressive. It's to just do what we call active surveillance or observation or careful watching or watchful waiting. So there have been different terminologies over the years, but currently we call it active surveillance. So because we know that prostate cancer grows very slowly, and it kills very few relative to the amount of people with prostate cancer, we know that we have time. So this making the diagnosis does not mean the patient has to undergo any dramatic treatments other than close observation, depending on the stage at which it's found and the type or what we call the grade of the tumor. We can tell after a biopsy whether or not the cells appear to be very, very malignant looking, that they have a grade that we associate with the probability of earlier spread than some grades which are lower, which can sit there for years, 10, 20 years before you have to worry about it. So the active surveillance has become, and as I talk some more, you'll understand why, a good method in many cases. There's also surgery. In surgery, it's called a radical prostatectomy, whether it be by a conventional way of major big surgery of opening up with a big scar, or as many of you have heard about, the robotic type surgeries, which now seem to be the majority of the way that prostate operations are being done, may be good for many men. However, there are many that it might not be appropriate for. They could have other illnesses that would put them at risk for going on to surgery. And frankly speaking, there are other options. If I discover the prostate cancer and you're 85 years old, you might not want to go to surgery at 85 years old. The surgery probably has a higher risk of killing you than the prostate cancer. So you have to take those into consideration. There's other options, including radiation treatments. At the last time I did a little checking on this, radiation and surgery at about 10 years carry almost about the same expectancy of whether it be recurrence or life expectancy. So it's actually a very good option, even for younger men. However, depending on how many years of good quality of life one may have in the future, one may choose to go the surgical route versus the radiation route. And again, that's an individualized approach. The other treatments include a combination of radiation and chemotherapy or hormonal therapy as well. And again, that depends on the individual, the grade of the tumor, how aggressive it appears, and the overall health of the individual patient. So it becomes a more personalized approach between the patient and their physician or healthcare person, whether it's an oncologist or urologist or your internist or family practitioners. Who's at risk? Well, there are some factors that we believe that influence the risk of developing prostate cancer. Number one is age, as we talked about it. You know, over 60% of them are men over 65. You saw that on the Weiss slide, and that was true. African Americans are at higher risk. You saw that on our slide also. And then socioeconomic status, as it occurs, it seems to be for everything in health, that the higher death rate for men with less than 12 years or high school education, which probably more reflects in terms of the socioeconomic levels of poverty versus access to healthcare. And those are all probably lumped together while you have folks with less education probably having a more disparity in the healthcare that they receive, and hence the discovery at an early stage of things like prostate cancer. The same holds true for women with breast cancer, we found. About 5 to 10% of prostate cancer may also be inherited. So if you have a strong family history, if your father, your uncle, both sides, whether it's on your father's side or your mother's side, have a history of prostate cancer, you have probably a 5 to 10% higher risk of inheriting as well. Some of the signs and symptoms of prostate cancer. Most early cases of prostate cancer have absolutely no symptoms whatsoever. In fact, most of the concerns that we have when men say they have some urinary difficulties, whether it's getting up at night for urine, we call that nocturia, or frequent urination, have to do with something else other than prostate cancer. A lot of times it could be a bladder infection, or it could simply be an enlarging prostate, which tends to be the highest in older men. Some of those symptoms, as we said, frequent urination, especially at night, a difficulty in initiating urination or inability to urinate, or pain during urination, or a weak stream, or urgency. You know, when you gotta go, you gotta go. A lot of those have to do with the prostate, but most of it is not due to prostate cancer. It's due to an enlarged prostate and a condition that we call benign prostatic hypertrophy or benign prostate enlargement. Of course, it's on us to determine whether that enlarged prostate that patient has is truly benign, or is there evidence of cancer in there. So, since we can't really prevent prostate cancer, what can we do for early detection? So, we found out that early detection probably offers the best chance of discovering the cancer at an early stage. But we also have a problem in that detecting it early can lead us to false assumptions that something needs to be done, and the treatment might be worse than the cure. The treatment might be worse than the disease. So we need to be careful. Well, what are some of the things that that we can do to detect early? Everybody knows about the blood test. It's called the PSA, or the prostate-specific antigen. Well, the truth of the matter is that, yes, the higher the PSA, the more likely it is that there may be prostate cancer, particularly if you've had baselines and you've seen that over 2 or 3 years, it's rapidly rising. That's usually a caution sign that something is going on. However, I've had patients with PSAs that have been more than 10 times normal, and they've been biopsied 2, 3, 4 times, and it's always been benign. And we've had a few, not the majority, who've had a normal PSA, but they have prostate cancer. So there are times when prostate cancer does not cause the PSA to be elevated or significantly elevated. So again, it has to be individualized based on the history, based on the examination, and the conversation between that patient and their healthcare provider. The PSA, without going into a lot of scientific stuff, it measures a protein that's produced by prostate cells. And, and this protein spills into the blood even before prostate cancer. But with prostate cancer cells, it tends to be higher most of the time. But it's also high in the benign prostate enlargement, and it's also high in the inflammation or infection of the prostate too. So that's why whenever we see someone comes in and we happen to do a PSA and it's elevated, we want to make sure it's repeated under certain conditions that would allow us to determine, is that a true value, or was it falsely high because of infection, inflammation, did the person have some recent trauma, or was it a lab error, which we find sometimes. And then there's that finger test, so to speak, the digital rectal exam. Neither one of these by themselves is a great tool by itself. Combined together, they're better. But still, even the two of them together doesn't always tell you what's going on. Again, you have to individualize it by patient. You've got to talk to your physicians. My role here is to get you to ask the right questions when you do see your physicians. So there are some official screening guidelines that the Cancer Society put out. And they say most men should receive the information about their prostate beginning at age 50. And those at increased risk with first-degree relatives that were diagnosed with prostate cancer before age 65 should probably receive this information when they're in their 40s. And that information is, what is prostate cancer? What is the prostate health? What are your risks? And what are the risks and benefits of testing? Because in years gone by, a lot of PSA testing was done. And if you tested 1,000 men, you're going to find a lot of them with an elevated PSA. Out of that elevated PSA, you're probably going to be told that you need a biopsy. The biopsy itself carries risk: bleeding, infection, pain. Out of those biopsies, you might find a few of them that may actually have prostate cancer. But in those prostate cancer, a lot of those don't need treatment immediately. And some of them probably never, ever will need treatment. So you're doing procedures in cases where you may not need to, running the risk of side effect and complications. But let's just say we did biopsy someone and it turns out that it was the type of prostate cancer that we don't want to watch. We want to do something about it. Well, what are the treatment options? As I said before, surgery, hormone, combination of radiation and or chemotherapy, or as we said before, watchful waiting or that active surveillance. If detected early, the 5-year survival, local survival rate is almost 100%, meaning that if we detect it early and it's all localized at a stage 1 or less, your chance of being alive 5 years later is 100% from the prostate cancer. Now, if you've got heart disease and everything else, that's a totally different story. But we're talking about the survival rate strictly from prostate cancer. In other words, the chances of it killing you in 5 years are 0. The overall 5-year survival, taken all stages, whether it be stage 1, 2, 3, and 4, is still about 99%. So even at stage 4, many men will survive 5 years. Now, obviously, the more advanced the stage is, meaning stage 4 means that it's spread distantly, maybe in the bones, the less the chance that you'll be alive 5 years, particularly if it spreads to major organs such as the brain, which prostate cancer does do. And when it does go to the brain, the 5-year survival does drop significantly. So, but overall, from early detection through stage 4, you still have almost a 99% survival from this disease at 5 years. We weren't here to talk about testicular cancer, but while we're talking about the men, we really should actually just mention that. You know, when I started medical school back in 1979, testicular cancer was almost a death sentence. And now it's 99% survival, 95% for all stages. And it's fairly easy to detect. We suggest that men over the age from 30 or even younger, especially if you've had any kind of cancers in the family, to do a self-testicular exam monthly or every other month and report any concerns to your physician. Some of the symptoms of testicular cancer is one testicle may be larger than the other. You may feel a lump that you didn't think was there, and many times it may be painless. Usually, if it's painful, it's usually more of an infection or inflammation than it is a cancer. So do a monthly or every other month self-check and make it a part of the yearly exam. We see the risk in the, like I said, about 30 years of age to about 45 years of age. Overall, cancer risk, stay away from tobacco. We started off the talk by talking about lifestyle modifications. Healthy weight, minimum of 30 minutes average moderate physical activity per day. Limit the high-fat foods, which tends to be the more animal-based foods. Have a diet that's more rich in plant-based. Limit the intake of red meats and alcohol. Know your family history, know your own history. Talk to your physicians, talk to your healthcare providers. Have regular checkups and follow some of the screening guidelines. They're put out not only by the American Cancer Society, but many of the medical specialties, as well as a United States Preventative Services Task Force, which is an advisory group that advises the government on how to do appropriate screenings. They take a look at what all the other organizations are doing, sort of like what the FDA and CDC did recently for the COVID virus, and give advice as to what should be put out there for the public. I'm going to switch over because this slide is not so easy to see here. I think it's a little better on this one. So just in cancer in general, we suggest that between the ages of 21 and 39, if you are high risk for any of these cancers, you start to talk to your physician about it. So if you have someone in your family who developed colon cancer at age 50, in their 40s or early 50s, they develop prostate cancer at those ages, or in some cases where there's many of the women with breast cancer or ovarian cancer, some of the men also carry a gene that can also put them at risk. So we suggest that early screening will begin if you have this family history or know that there's a genetic predisposition. Otherwise, most cases are looking at ages 40 and up. Colonoscopy, as you guys probably have known, is recommended for age 50 and up, but lately the recommendations is coming down to age 45 now. So look for that to happen. Breast cancer screening, again, we're not here to talk much about it, but women between the ages of 44 should have a choice of starting their mammogram screenings, and certainly age 50 and over should have regular screening mammograms as discussed with your family. Lung cancer screening, people at higher risk who have been smokers, we have testing for that. Happy to say that every one of these testings are available here at Weiss Hospital. The American Cancer Society offers help for people diagnosed with cancer, as well as resources for caregivers of people. And their number is pretty easy, 1-800-227-2345, or as we like to say, 1-800-ACS, American Cancer Society, 2345. If you want to volunteer and help, they provide rides to cancer visits. They provide fundraising opportunities, fun opportunities. A lot of the volunteers run in the marathon, the Chicago Marathon, and other activities throughout the year to raise funds so that the services that the patients get from the American Cancer Society are free of charge. There's absolutely no charge for any information or any of the services provided by the American Cancer Society. And there again, in terms of Weiss Hospital, though we're a small community hospital, we do provide screenings for almost all the cancers that we talked about. For prostate cancer screening, we have a lot of primary care physicians who take care of most of the patients here. I'm an internist, which means that my youngest patients tend to be about 16 years of age, all the way up. My oldest patient right now is 101 years old. So yes, so that's what internal medicine does. That's what internists do. And at Weiss, we have a lot of internists. We have a physician referral line. We have the senior center here where you can get all the information there. We have colon cancer screening. We do colonoscopies here. We recently added a group of GI specialists who had started here at Weiss also. So we're actually boosting up that program as well. Next, this month of October is Breast Cancer Awareness Month. So we have mammogram screenings in our X-ray departments. So you get your referrals, and actually for a screening mammogram, technically you don't even need a referral. For a screening mammogram, you can actually get one done without a referral. We suggest you get a referral from your physician because if it were abnormal, you need someone to talk to. So we would suggest that. And I think that's it. I'm open to any questions. Why don't you come and pull that out for me here? I see one here.
She presented with the PowerPoint and full screen, which I was trying to do.
Yeah, it was a little difficult to, but I think everyone could see the slides pretty fairly though, right? Okay.
So if you have any questions from those who are on Zoom, please type them in the chat button or unmute yourself. Does anyone here have any questions?
No, we're still sharing.
No, it's not. Okay, did anybody have any questions?
Yes, I do.
Okay, we have a question here.
Yeah, doctor, I heard that what you said about maybe the family or the mother or the father, they have history of prostate. How prevalent it is for somebody that parents or the either father or mother don't have history of prostate? How prevalent is it with somebody that has no history? Is it common that they have that?
Yep, actually, let me repeat the question in case they didn't hear. The question was, she understands that if someone has a family history of prostate cancer, that they're higher risk. But how common is it for someone who has no family history to have prostate cancer? Actually, most men who are diagnosed with prostate cancer, they're the first ones in their family diagnosed with prostate cancer. And the same is true for breast cancer. Most women who are diagnosed with breast cancer today have no family history of it. They're the first. Any other questions? Unmute yourself if you'd like to. Let's see.
You said that there are many screen for prostate cancer and different things. Then we can just, come and have that checked.
Okay, so the question from the gentleman in the audience here was, is there a way to just come to the hospital to get a prostate check? And the answer is, you really have to go through your healthcare provider. You have to go through either your physician, doctor, nurse practitioner, whether it's in one of the clinics or so, because number one, there should be someone who sits down and interviews you, someone who examines you, and if felt to be indicated, order the necessary testing. So that requires for you to consult with a healthcare provider. Does that answer the question? Correct. Yeah, you can't just walk in to the front and say, I want to get a prostate blood test. No. In fact, it's actually strongly recommended against to have mass screenings of prostate testing like that. A few years back, you heard it on TV, you heard advertisements, you heard it at churches, you heard it at the many community groups where they said, hey, next Saturday, we're going to have this screening and men can come and get a PSA testing. Well, we have recommended against that for a number of years now because if you remember in my talk, we talked about the risk of harm in testing or treatments.
Right.
And we were finding that you would have 1,000 people come in for a Saturday testing, and many of the ones who even turned out to have prostate cancer were being treated too aggressively, that they were having more complications of the treatment than actually the disease. So the societies together looked at all that data and decided, no, it needs to be more individualized. You need to explain to the patient what their risk may be and what is the risk and benefit of testing and or treatments. And choose wisely.
Questions? Michael? Already did. Oh, I wasn't sure. I saw you. Did you all have any more questions?
Michael says no.
Okay,
I appreciate the good presentation. Thank you.
thank you.
Thank you, sir.
So I'm gonna send out, for those of you that are virtual, I'll send out a survey on this, prostate lecture. For those of you that are here, do you have any questions about the survey? So the first question is basically asking, how many men are there in your family? We know that prostate cancer, the prostate is something that only the man hears. But for you, that females are in the audience, think about the number of men that are in your family, your sons, your grandchildren, your brothers, your father, and your immediate family, for your partner.
There's a gentleman with a question. Yes, sir.
Yeah, so should you ask your healthcare provider for like a rectal exam?
Well, when you go to your healthcare provider, part of your annual exam, once a year minimum exam, should have that discussion about a prostate awareness. And if it's indicated to have a digital exam, the finger test, so to speak, the digital rectal exam, it should be done. There are many men who fear that, and they'll stay away from the doctor because of that. So one of the things we have adopted ourselves to is try not to put that as the main reason why we want the patients to come in. Because there are other health issues that the man needs to talk to his physician about. I mean, there's the diabetes, there's the high blood pressure, all of those kill more than prostate does. And what we found years ago was that if we're just pushing hard for men to come in and they're going to get a digital exam, a lot of men didn't want that. However, after having a sit down discussion, many men will say, you know what, I should have it done. Or if they don't, there is still, through the conversation and other methods, that you can risk stratify that patient. Now, if a man comes in and he's having urinary symptoms, he definitely should have a rectal exam done. The other thing is, whenever the patient is due for their colonoscopy, and anytime we do a colonoscopy, we're going to do a rectal exam also. But that's only every 10 years, though, right? If a colonoscopy is normal, it's only done every 10 years. But there are opportunities, and it should not cause the patient not to want to come in. They should come in anyway. And if it's decided between the physician and the patient that he does not want a rectal exam done, there are other ways of getting at the information.
Where? Folks, every time I went, that's one thing I said, it should be a way to go around that one.
Yeah, well, again, there shouldn't be a fear for it. But, if I felt that this patient was not going to show up to the doctor because of that, I'm going to have a longer discussion regarding, well, what's exactly going on? What's going on with your urination? And we may apply a PSA and say, listen, this may come back normal, but it still doesn't say that it's 100% correct. And we may want to trend those. One PSA never makes it. And if somebody is getting up in age and they're telling me, well, I don't want no rectal exam, we may do a PSA annually or every other year. Now, if the patient in the course of my interview seems to be at high risk, I'm going to do everything possible to talk to that patient about what they need. Because we're no longer talking about just screening. We're talking about getting to the root of a problem you're having.
Got a quick question.
Yes, Michael.
I'm doing a urology doctor thing. And should he be testing for prostate cancer?
You know, it's like saying if a woman goes to a gynecologist, should she get a pelvic exam? And the answer to that is yes. I mean, that is a urology specialty. If I went all the way through to refer a patient to urology because of a urinary or prostate issue, I would expect that urologist to do a rectal exam. And I'll be honest with you, if in the course of my interview with my patient, I felt that, listen, you know, this looks like I am going to 99% refer you to a urologist, I will probably not do a rectal exam and save it for the urologist to do, so it won't put you through unnecessarily. It's a similar thing when I see a woman in my practice. You know, if those symptoms dictate to me that, hey, you need to see a gynecologist in the next few days, I'm not going to put that woman through a pelvic exam when I know that she needs to go and see the gynecologist within the week, and the gynecologist is going to do their pelvic exam. You know, we use common sense and decency, and you know, and planning and educating and communicating.
Okay, thank you.
Yeah.
I'm
I
off.
hope that answers your question, Mike.
Take care.
All
Thank you,
right, thanks,
Michael.
Mike.
Thank you, Judy.
You're welcome. You are welcome.
We still have a few minutes before your other gentleman. Yes, ma'am.
Ask this question. The problem is patient feels scared, like go to a doctor and then you go to the doctor. That scares a lot of patients. How do we get the public to be informed that this is necessary? Because you know, like one of my friends used to say, what you don't know, who makes you upset or something like that. But it will kill you. You know, how do we get the population to get involved that this contest that you are scared of can save your life? Okay, I don't know how we can get.
Yeah, well, I think it's, yes, I think it's with any health problems. You know, we need to recognize that our goal is to try to stay as healthy as long as possible. We're not going to be living forever, but during our formative years, during the years that we are here and able to do for ourselves and do for our family and do for our community, we would like to be healthy as possible, you know, and there are so many things that need to be checked that I just don't think focusing on any one thing is necessarily. So if someone is worried about coming in, like I said before, for a prostate exam, there's other things that they need to come in for. You know, diabetes is rampant. You know, someone who smokes needs to be counseled regularly by their physician. You know, there were two things that were observed back in the 80s, early 80s maybe, when they asked women, why did you get a mammogram? This was in the early years in the 70s when mammograms were being promoted most, and they were trying to get the numbers up, and they surveyed women and asked them, why you get a mammogram? The number one answer was, because my doctor keeps telling me to do it. And when they asked the opposite question of the woman who didn't get it, how come you didn't get a mammogram? Oh, my doctor might have mentioned it once or so, but he never said anything. The same thing held true for cigarette smoking. When they asked the smokers who quit, why did you quit after all those years? Because my doctor kept bugging me till I quit. And when they asked the folks who say they see doctors regularly, well, how come you still smoking? Well, my doctor never really complains. You know, so as a healthcare provider, it's on us to do that. But it's also on family members. Don't feel like you are bugging someone when you are telling them something that's good for them. You know, that's what coaches do. If Michael Jordan's coach said, oh, all right, Mike, you're tired, take a break, and then keep pushing him, we wouldn't have had 6 championships in Chicago. So coaching doesn't mean to bring yourself down to their level to be pity for them. Yes, there's empathy. You understand where they're coming from. And I let my patients know, whatever your decision is, I'm here for you. But I'm going to keep giving you the guidance. The guidance as best as the science can tell me right now. Because I'm a scientist at heart, right? But I'm a human being too. And, you know, and I'm going to be here. So you talk to them about their entire health. You know, the prostate isn't separated from the rest of the body. It's part of the body. Just like your mental health is important, especially now with the pandemic and people being isolated and maybe depression. So, yeah, so I hope that helps.
Yeah, it does. Thank you, Doctor.
Yeah.
Thank you so much. Sometimes not in this day anyway, no matter what you tell them, they say you will die anyway, it's like. Not a big
Sometimes
deal.
you can use reverse psychology. with
Sometimes,
patients.
but I heard a talk a few years ago by some folks. I think Sanjay Gupta was in that bunch also. And what they said was, you guys know about batteries, right? Alkaline batteries and right. Well, there's some batteries like the ones that are like mercury batteries. They use them in smoke detectors and stuff like that. As an alkaline battery, if you shine a light over time, it gets dimmer and dimmer and dimmer and dimmer until it dies, right? But some of the batteries, like mercury batteries, they last like this, and all of a sudden they go boom. And the discussion was, wouldn't it be good to die that way? Instead of dying little by little from all of the different things, I got a stroke here, a heart attack here, and I'm, now I'm paralyzed and I'm etc. Wouldn't it be good to live a long, healthy life and just don't wake up one day?
Yeah, that would be nice.
Unfortunately,
It doesn't happen.
it doesn't happen. So we got to do the best we can to try to live a healthy life during those formative years. And when it comes to the point where everything has been done that can be done, we need to make some serious decisions. Do we want to be hooked up to 1,000 different tubes and things and etc.? And that brings up something that I would like all of you to take into heart. Declare to your family and relatives what your wishes will be. Doesn't have to be DNR, but it should be an advanced directives. In other words, this is what I would want done if I'm ever in a position where I can't make that decision myself. And this is the person or persons that I would name as my agents to carry that out. It's called an advanced directives. It could be a full DNR. It could be a limited DNR. It tells you what your wishes are. Oh, yes.
This is so important.
Yeah. And one of the things that we should be discussing at least once a year while we're having all this talk with your physicians is that, once a year. And in fact, by law, since the Affordable Care Act got in place in 2012, 10 years ago, everyone who has any kind of an insurance, whether it's Medicare, Medicaid, private insurance, is entitled to one visit a year. Listen to this, guys. You're entitled to one visit a year, which has no copay, no deductible, and all it takes is for you to go in and sit and have this discussion with your doctor regarding your overall health and lifestyle. Maybe involve getting whether it's some blood testing or other things. And it's once a year. It's called your annual wellness exam. And it's free. Everybody pays for it. By law, any insurance in the country that insures you has to give you that once a year. It's called a wellness screening exam. And it includes talking about advanced directives, talking about the risk factors, talking about your family history, your social history. It's guidance. Yeah.
Thank you so much, Doctor.
Good. All right. Thank you guys for coming. I really appreciate it. And thank you.
Dr. Rose, for taking time out of your day and pulling the lecture together for us and coming out and just being honest and sharing. And you went so much beyond just prostate cancer, but thank you.
Yeah.
For all the words.
Thank you. Yes, sir. We got one more question here.
Yeah, did you ever see the movie Break Room Roulette?
Which one?
Break Room Roulette.
No, I didn't.
Okay, when he was going to the filing store to be executed, he says, live every day like it's your last, and one day you might be right.
One day you may be right.
You may be right.
Yeah,
And
that's your last day.
today is the first day of the rest of your life.
That's good.
Is it possible, I know you're talking about having this exam, that exam, and that. I was going to a doctor. I think I've had pretty much every kind of exam you can have, fluids, this, that, and other, and if you come back every month, okay? I come back every month, and I'm going through these different tests, can that be harmful?
Well, it depends on what's wrong. I mean, there are times when certain testing are indicated. And frankly speaking, there are times when we're over testing patients. There are times when we're appropriately giving patients medications. And there are frankly times when patients are over medicated. Every case is individualized. It's hard for me to be a Monday morning quarterback unless I know the details. But yes, it is true that we very often overtest, we overtreat. Yes. And then you look at certain other parts of the population and they don't get tested properly. They don't get treated properly. It's sort of this, what we call the disparity in healthcare.
And the prostate medication also has its effects.
Yeah, every medication that you take has a side effect.
Right.
Every medication you have to weigh the benefit versus the risk. What are the benefits? Do they outweigh the risk of not being treated?
But there are some that don't seem like our wives or whatever do not get that information.
Well,
some of the side effects, our wives don't get that information.
well, that's why it's important, in my opinion, that it's a family thing. They say that it takes a village to raise a child. It takes a whole village.
Dr. Rose, I think he said when men who have prostate issues act crazy, the woman's supposed to accept that.
Well, I'll be honest with you. Just like when we have a woman who may have breast cancer and we put them on tamoxifen or one of those medications and it makes the hormones go wild, men who get hormone treatment, Lupron, have some of the same issues. So I think that it's really, really important that, if a man is in a relationship, that his partner is part of that discussion. Just like a woman who has breast cancer in a relationship, because we're all in some kind of relationship, whether it's siblings or parents or child or spouses, they have to be part of it. No one should be isolated.
And you were asking if Dr. Rose sees women. Dr. Rose is an internist, primary care physician, and yes, he does see that.
In fact, a bunch of my patients come to the senior center. All right.
Thank you so much.
Okay, thanks. I think you guys have another presentation coming in about 7 minutes.
So I would like to,
Go ahead.
he's a good doctor too.